guess I should have put everybody in the room. Good morning. Good morning. How are you? I'm good. Wait a minute, you low on my end. Maybe it was me. I think I turned you down. You still hear the feedback?
Yeah,
A lot?
actually, before you did something, it was better.
Uh, I turned you up. Is that better?
Uh, yeah, it's better, but it's still there. But it's
Okay. Let me turn you down. Okay. Let me turn me down. Maybe it's me. Okay.
not. All right.
All
Oh,
right.
better.
It's better.
Yeah.
Yay. Good morning. How are you?
Good thing.
Yes. How was your week? I'm back in the swing of things. And still acting brand new. How was your week?
It was good. It was a week. Yeah, I'm glad we had a 3-day weekend.
Sir, sir. It felt like the longest week ever. And I really don't know why. Just wow. Hopefully
I'm
next
glad it
week won't
wasn't just
feel
me.
long too. Huh?
I'm glad it wasn't just me.
Yeah, no, no. I've heard a lot of people say the same thing. Like, what is it? I think we also were teased with some gorgeous weather this
Yeah.
past week, and so people wanted to be out there and get out there, and then stuff was holding them back, and they couldn't. And so, I think all of the things happened this week. So yeah. Oh, well, I'm good. I'm glad to see you. I'm glad to see you.
Like,
Ah, all right. Well, let's get into this thing this morning. It's it's just funny. Let me just start there. The stuff I ran into this week, I was just like, okay, all right. They coming for everybody, ain't they? But anyway, welcome. Welcome. This is episode 72. Do you know we had 72 episodes on this thing? I know, I know. So, welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, entrepreneurship, all the things that the AMA is about. No, I'm kidding. Strategies, what we gonna do in these streets of healthcare, all of the things, you name it, we will discuss it. And as you come in, don't forget to hit the like button or thumbs up. I am Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And let me just ask you first and foremost, do you know what it takes to be a certified marketable? That's the key here in this space. Marketable medical coder. Well, before I introduce my co-host, let me share with you some information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I love that little ad. It was the very second ad that I put together. I like to play and experiment. And I was like, let's see. And threw all of that together, and it's still catchy to this day. It's been in rotation forever. All right. So if you are in Clubhouse, and welcome back to Clubhouse. Yes. Feel free to click the link, the pinned link at the top of the page. And if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, for YouTube, Facebook, and LinkedIn, you can check the video description for the link. I promise you it's in there. Just scroll down, you'll find it. So, joining me today is my co host, Mr. Jesse, the registered trademark puts some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in healthcare for 30 years. During the pandemic, I created a company called the Coding Nurse LLC, where I help nurses and other healthcare practitioners with clinical backgrounds to transition into the wonderful world of HIM.
And isn't it wonderful?
It really is.
Isn't it wonderful? I mean, we gripe, we have our strong opinions about a lot of things, but at the end of the day, it is wonderful. It is wonderful. Good morning. Let's see who all in the good morning, Carlene. Good morning, V. Good morning, the crafty coder. Good morning. She says, good morning, crew. Happy Saturday. Yes, happy Saturday. Happy Saturday. And Lord willing, I can just put my feet up. I know I'm not, but it sounds good anyway. Put my feet up and rest on this Saturday. Let's see. Church announcements. Well, before I get to the church announcements, let me just remind folks that we are in conversation. And if you are on Clubhouse and want to join in the conversation, all you have to do is raise your hand. We will definitely add you to the stage to join in the conversation. And don't forget, your opinion matters here. So you don't have to be shy. It's a training ground. You can come on in and let us know your thoughts on some of the topics that we have for today. Or if there are other things that are burning and pressing in your spirit, you can feel free to come up to the stage and we will definitely have a conversation about this. This is always a dialogue. And so we believe in having a conversation. That's why there's two of us, so that because one person can't talk to themselves. I mean, I guess you could, but somebody might think you're crazy, but it's a conversation. And then for my Facebook, YouTube, and LinkedIn friends, you all know what to do. You use the chat. If you have a question, please put a Q first so that we know it's an actual question and we won't miss it. All right, let's see. Good morning, Tasha. Welcome. And she said, and everybody else. Good morning. All right, look, y'all on the road here. I feel something is already brewing in the air. It's always already brewing in the air. So, for those of you who are just joining us, today we are discussing medical coding shortages, and I say that with a question mark, and physician confusion. But first, let us get into our church announcements, which could pretty much be a topic in and of itself as I read through it. So, church announcements. Well, there are two. One I just thought about off the top of my head. So, Mr. Jesse, you know how you talked about the training manual for the CDI certification. Do you know that there's now a volume 2 that has been released?
Yeah.
And so, wait a minute. Where is my? The tea is out. Let me get my tea right now. Did y'all hear that spirit that just came out, that just leaped out? So
It jumped out.
I was trying to ease it, but it jumped out. So I'm optimistic. I haven't seen it. I don't know if you have gotten an opportunity to take a look at it to see if it addressed. I know you had several concerns and questions about it. I don't know if you had an opportunity to maybe see it, or maybe you could reach out and see if you can get a copy to see if you can aid. I don't know. I just thought I'd bring it to your attention that it was out, but you already know. Go ahead.
I feel like for our church announcement section, we're gonna need a little background music.
Okay, I'm gonna have to find some. I'm gonna definitely do that.
Just a
little organ. Yes. Look, we are kindred spirits. I promise you. Okay, I will be on the look for some organ music for the background. Okay. Church organ music for church announcements. Yes, I love it. Okay.
So, Clarice, I promise you. So first of all, I want to ask you: do you know this woman?
No, I don't know her personally. I've
Okay. So,
no, I know she does a lot of work with AHIMA. And I've seen her around, and she reached out to me before. Well, we had that conversation before she reached out. She was concerned about something that you had said before about with your job, you know.
right.
But no, I don't know her personally. I mean, it's all good in the neighborhood.
Because I thought you knew her,
I don't know her
and
personally.
I did not know that she was. How can I put this? I didn't know that she was a diaspora until I saw her picture
Okay.
in the ad that in the post that you liked when she was talking about the second edition, because I was like, because had she not been a diaspora, I would have gone in completely.
Oh, I didn't know you didn't know that.
Mhm.
Oh, I didn't know you didn't know that. Yeah, because I've seen her face. I want to say on LinkedIn. That's where I saw her, and that's where most of the interactions that I've had with her has been on LinkedIn. I want to say I may have also seen or had conversation through virtually, maybe in a HEMA space once or twice before, but that's it. Yeah, but as soon as I saw that, I thought about you, and I was like, you know
Really?
what? I just and again, I haven't seen the actual manual, so I don't know if some of your concerns or questions have been addressed. I hope so, because they were valid. I think, uh, especially
Well,
if it doesn't provide you with the information that you need to be successful on the exam. What's the purpose of the manual?
thank you.
If that's because I want to say the title or something about it gears you to believe that this is going to help you
Yeah,
prepare for that exam. And if it doesn't
yeah,
meet that objective, then if it's just kind of going over, generalization and general topics and not really giving you something that can help you, because why spend the money? You know what I'm saying? Why do that? I don't know. Prayerfully, it does all of the things. And maybe I can reach out to her and see if she want to come on and talk about her book. Maybe we could do that. That'd be fun. Sir. Or maybe, I mean, I don't know. I'm trying, you know me. I like to be optimistic. So I'm optimistic that this is something that
now, me personally, if I had to fancy a guess, I would say that there are some improvements because I know for a fact that somebody else had written to AHIMA about the quality of the book.
really.
So
Okay.
yeah, so I know that I'm not the only person who felt like that,
Okay.
and I don't know how many other people have done so. So I'm quite sure there might be some improvement. Now, is it? I mean, I'm really willing to invest in buy in getting a copy myself so I can see because I saw the first one. So and to that end, AHIMA apparently is revamping their exams anyway because their healthcare privacy and security exam changed last year, late
Mm-hmm.
last year.
Mm-hmm.
So, and this exam, the CDIP, is changing effective June 1st. So, I'm hoping that
What changes are they making to that?
they're 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 updating the domains.
Okay.
So the exam is changing, and they have a on their website to their credit, they have a nice little crosswalk that compares the old domains to the new domains of what information was basically added or modified.
Okay.
But I
Okay.
just hope that the book has adjusted as well, and I'm quite sure there are some improvements because I'm sure they got a lot of feedback.
Well, that's good. That was a gem right there. So people who are interested in taking that CDIP exam, make sure you go out to AHIMA's website to see what those domains are. That usually helps you determine, some of your study strategies,
Yeah,
and making sure that you hit all of those things that can be on that exam, and you got a comfort level of your knowledge as you go into that exam. So that was a good gym. That was some good tea right there. That was hot.
And the good thing about a HEMA, and I've always told people this in reference to any of their exams, you have to go to their website and read their domains and
Yes.
look at what is being asked,
Yes.
because none of their study guides, none of them, cover everything on the exam.
Mm-hmm.
So that's why you have to go and look at those domains and read what it covers, read what the key points are under each domain, and make sure that you understand what is asking. Now, the other exams are enough to get you by. You'll pass it if you use the study guide. My only issue with the CDIP is like the first edition was alone, it wasn't hitting it.
Mm.
But that crosswalk is a must.
All right.
You
All
have
right.
to. You have to.
Well, that's what's up. That's what's up. I love it. All right. And then my second church announcement was related to the announcement that came out that we saw some background information. Like you said, we should always preface with the background. So Cigna was going to require submission of documentation to support the use of modifier 25 when it was built with ENM CPT codes 99212 through 99215 and a minor procedure. Well, they are delaying that implementation and requiring the submission of that documentation. And so that came out. And they were walking it through. My understanding was they were dripping that in various states, and they have decided to put a pause on that entire thing. I wonder if I can bring this up. Hold on, let me see. Because this was a gym, and I felt like this could have possibly became its own topic in and of itself. After I dug deeper into it, I said, well, wait a minute. Wait, before I go there. She says, I feel the same way about the CPC study guide. I adjust my curriculum rule. Oh, wait till we get to one of our topics today. We gonna have a discussion about that. Hold on. Hold on. Okay. Let's see. Share my screen. I know I don't have two monitors here. A window. I think we could do it this way. I hope we could do it this way. Let's see. Let's see. Can you see it?
Yeah, I can see it.
Okay. Okay. So here's the information in their policy that talks about their delaying the implementation. But I thought this was really, really comprehensive and gave a lot of information. And it provided some additional information on like modifier 59, modifier 57. And so I wanted to bring to your attention, where was it? So here's their reimbursement policy, and it says they allow separate reimbursement for E&M service or office visits when reported in addition to a procedure on the same day of service if the CPT or HCPCS E&M service code and a procedure performed at the same patient encounter are individually and separately identifiable, and modifier 25 is appended to the disallowed E&M code, and CMS National Correct Coding Initiative, or NCCI, or Cigna defined edit allows a modifier override, and you see all these ands. The E&M services provided must meet the criteria as defined in the current CPT E&M guidelines for code section 99202 through 99215. And I don't know why they still got this in here, but anyway, 1997 CMS documentation guidelines. E&M codes outside the 99202 through 99215 range must meet criteria as detailed in the CPT Refer to the evaluation and management reimbursement policy for additional information. Um, and then this goes on to talk about modifier 25 usage, um, and just background information on it. It says that for E&M services on the same day, a procedure is also performed by the same physician is included in the payment for the procedure. The E&M service code should not be separately reported. In some instances, a significant E&M service is rendered that is separately identifiable from the procedure performed in the same session. The separate E&M service must be significant enough to require a separate service, i.e., address a new or distinct problem. Um, and so one of the reasons, or one of the, I think, premises behind, and this is my opinion, one of the premises behind the additional documentation request that Cigna initially had was they wanted to see the documentation of that separately identifiable E&M service and whether or not there was a new or distinct problem that was different. But I guess they got a lot of pushback, and they're just putting it on pause. They didn't say it was going away. They just said they were putting it on pause. Another thing I want to talk about, and Mr. Jesse, you brought this to our, you refreshed this information for most of us, hopefully all of us, and it wasn't brand new, about the minor procedure definition and the global days. So a minor procedure has global days of 0 and 10. And so this is when the disallowed code is an E&M CPT code with modifier 25 and a minor procedure. The documentation should demonstrate that E&M is significant and separately identifiable. Again, CMS defines a minor procedure with a global day of 0 and 10. And then this is quoted: in general, E&M services on the same date of service as the minor surgical procedure are included in the payment for the procedure. The decision to perform a minor surgical procedure is included in the payment for the minor surgical procedure and shall not be reported separately as an E&M service. However, a significant and separately identifiable E&M service unrelated to the decision to perform the minor surgical procedure is separately reportable with modifier 25. The E&M service and minor surgical procedure do not require different diagnoses. CMS identifies the global days on the National Physician Fee Schedule relative value file, and CMS updates this file multiple times throughout the current year, which can result in the reassigning of the global days. So you have to check that out. That's another little gem there that if you are wanting to make sure and double check whether or not it's still considered a quote unquote minor procedure, you might want to check that out prior to submitting those claims. Go ahead.
And just one little interjection. And CMS has a nice little spreadsheet that you can download that has the global days.
It does. It does. You are absolutely correct. It says examples of incorrect use of modifier 25: appending modifier 25 to a CPT or HCPCS service code that is not an E&M code; appending modifier 25 to a CPT or HCPCS service code when the patient's condition does not warrant an E&M service in addition to the procedure performed on that date; or using modifier 25 to indicate the need for a major surgery the day of or day after the E&M visit. Modifier 57 should be used in that case. So again, there's some additional stuff in here if you want to read. I'll place a link to this PDF in our in the description box below. So yeah, that was a church announcement that became an actual topic of itself. Let's see. Crafty Coder, I think it's dumb to decide not to. I was in a group on Facebook and told them, make sure you work on documentation, because if you think they not you crazy. And then she highlights separate. And I think that is all related to that church announcement. All right. Mr. Jesse, did you have any other comments on that before I get into one of our topics for the day?
I just wanted to just add that this is why it is so important to stay up on current regulation because it changes constantly. Like, and this is what people don't understand. Like, you might have this situation down pat today, and in 6 months, they have made a little modification, and the whole landscape changes.
That's right. That's right. Oh yeah. Okay. She said you're crazy if you think it's not coming back. Oh, I believe it's going to come back, and I believe that it's going to set precedents for others. I think other folks are going to jump right on this because that's low hanging fruit. I think others going to be like, you know what, we should have asked for this a long time ago. Because I think it's twofold. It's one, it's a way for them to better manage what's happening with these issues around modifier 25 and E&M services and minor procedures. And two, so they're being looked at. And so oftentimes some of the criticism for them is that they are not doing all that they can do to safeguard um, these dollars. And right now our government is they in the cushions of the couch, like, where is some coins? So they looking for it all. They gonna do what they need to do to make next month's mortgage or rent. So I think this really is gonna set precedent. And maybe they're gathering more support from others to jump this off at the same time. I don't believe, I'm like you, Crafty Coder. I don't think it's going away. They said they went to get the cavalry. Right. I don't think this is going away. I think they're going to get some reinforcements. They coming in like and working it out. Were you gonna say something, Mr. Jesse?
I was just gonna say, like, they're in the background crunching some more numbers and seeing how much this is really going to affect things and see how they're going to be impacted from a business standpoint, because everything comes down to money.
You know it.
So
you know it.
They want to see if it's going to create an undue burden for them.
You know it. You know it. Okay. So, and I thought all of this was related. So the other thing was, our topic was coding shortages. So my friends over at the AMA, when I tell you, boy, if I had a whole bunch of money, I would be a member, because Lord, the things that you get over there, just being on the outskirts. I'm sure there's a whole bunch of other stuff to see if you remember, but just being on the outskirts, boy, the AMA is everybody's business, right? Right. I thought the American Hospital Association was in it. They ain't got nothing on the AMA. Hats off, y'all keep me entertained and keep me on my toes and keep me looking for the regulations and guidelines related to some of the stuff that's happening over here. So in these quote unquote coder shortage streets, the AMA, there was an article that says they want to address another healthcare shortage, and it was for medical coders. And I said, well, wait a minute. What? Do they know something we all don't know? Because I hear folks like, we can't get a job. We out here getting certified. We doing all the things. We putting in the resumes. We sending we putting new resumes and new cover letters together for each and every particular job that's out there. Some of them have some challenges because they're brand new coders. So you got that challenge you have to jump over, but you got some seasoned coders who be out here and they just testing the water, seeing as some coins are being diverted from one area to another area to make it a little attractive for folks to come here or go there or do whatever it is. And everybody is all about balancing and doing what they need to do as it relates for them. So folks is peeking around the corner like, well, what are y'all offering over there? And what are y'all offering over there? So I'm hearing in these streets, folks are out here, they looking, they trying to, but either they're not getting information back. They're being told they don't qualify for the position. They're being told, we looking for nurses. They being told all kinds of things. So I was curious when I read this article, like, well, what is this all about? So let me see. Let me open this up. Let me share this with y'all too. I said, well, what is happening? What is this all about? And what is the AMA doing? What how,
Exactly.
how did they get involved? So so this comes from Jennifer Lubell. Prayerfully, I'm saying her name correctly. Um, and so she talks about that there is a 30% shortage in medical coders across the nation. And healthcare organizations need coders as they ramp up their own growth strategies. So she said it's not necessarily a significant turnover. Well, this is from Rhonda Hale, who is the vice president of finance for Baptist Health Medical Group. She said it's not necessarily a significant turnover issue as much as it is growth. So they need additional coders to support how much they have grown over the last few years. And so they have partnered with the AAPC, the American Academy of Professional Coders. And it says they're the world's largest training and credentialing organization for coders. I didn't fact check any of that. I'm just providing what I read. With the AAP's help, Baptist Health created its own, quote, university to certify coders from its own employee base and a few external candidates. It recently graduated 18 of the 20 that enrolled in the program, offering them a work from home opportunity to grow their career. So basically, this article kind of sums up how one organization um, partnered with one of the national coding credentialing organizations to kind of grow their own. But the first thing that stuck out to me is we did this back in the 90s, right? I mean, this is not new, so I don't know why this was a whole thing. And but glad somebody has uncovered a method in kind of helping advance the careers of some of the folks that are within their organizations. It says what makes their program unique is that accepted candidates would continue to receive a paycheck while studying and then sitting for the AAP Certified Professional Coder exam. So I can speak for myself. What we did, again, way back in the day, when I worked at an organization, I worked at an academic medical center, and we had various departments. So we had cardiology, we had orthopedics, we had OB, we had all these different departments because it was a huge medical group. And we did the exact same thing to the point that she said, let me see if they need an instructor. Ma'am, wait a minute. To the point that we advertised to each of, so I worked in the administrative arm of the organization, and I worked in compliance, and we offered a program to assist with getting coders certified. This was a time when most folks had come up through the ranks and became coders. They weren't necessarily certified. Certification wasn't the jam at the time. It wasn't the big deal that people were looking to do because they felt like, oh, well, I learned this on the job. So it was mostly on the job training at that point. And so we were saying, yes, you may have learned it on the job, but certification was the way to go. And so the organization, and they also partnered with AAPC. And like I said, I'm dating myself. This was way back in the day when you had a gazillion questions and hours of time to pass the exam. You also had This is before they had a cumulative score. You had to have a score, a passing score in each of the various sections. So everything was broken down in 3 sections, and so you had multiple sections in each of the 3 sections, and you had to. It was a whole convoluted thing way back in the day, but we marketed to the different business units saying, hey, you have a specialty. You may want to make sure that you have some folks who are certified. Is there an interest? Folks was coming out the woodwork. We were actually, so they were getting paid to learn because they would come down to the administrative offices, and we would actually we would hold class right then and there at the administrative office for them to prepare them for certification. And they one of the things I think they initially failed to do was to put some contract language in that once you get your certification, you can't now just take your certification and run. The company that invested in you, you're gonna take your certification to work. So I think some of them initial classes, folks was like, I'm out. And they got a little smarter and changed some things with HR to make sure that folks did at least put, it was a stick and stay. You had to have so many years of service after getting your certification. Otherwise, you had to pay for it out of pocket. But yeah, so this wasn't anything new. So I was really tickled when I saw when I saw this for from the AMA regarding this. Like, oh, okay, this is what we doing. All right, Mr. Jesse, you want to weigh in?
You know I do.
I know you do. I said, let me just take a break so you can go ahead and get in there. Yeah, get in there.
The first thing that came to my mind is scope creep. Now they want to be they got their panties in a bunch over nurse practitioners overstepping. The amount of horrible documentation I read every day from doctors, and you trying to get involved and teaching somebody how to code? That's nerve. Charity begins at home, then spreads abroad. Get your house in order.
All right now. I said, wow.
And the main reason, in my opinion, that there is a quote unquote shortage, if anything, is because we have it's a convergence of things. We have, we know that the baby boomers were the largest segment.
Mm-hmm.
And as they begin to get old and their arteries start to harden and they come out the workplace, they're leaving these gaps. But what happened is.
Did you say, wait?
Yes, I did.
Okay, go ahead.
And what they did while they were sitting up there in these positions, they created a backlog. They started gatekeeping, and they started determining who was going to come in, how they were going to progress, how they were going to move around. So what they have done is they caused the shortage. Now they get ready to walk away, and then there are other people who have to come up with these innovative ways to kind of fill in the gaps. And the gaps should be on the job training because it should not. I know people who have been certified for 6 months. It takes them 6 months to a year to get their first coding job after certification. That's ridiculous. That's just like a nurse. Once you pass your state boards, waiting 6 months to a year for a nursing job. Once you get your license, they will crawl through your window to get you to work for them.
That's right.
And these HIM places should be the same way. It should not be this hard for a certified coder to get a job.
That's right.
These exams are not easy. And how dare them tell somebody, well, you got certified, but we still need experience. How are they supposed to get experience?
Exactly.
And it's not like, and even now, as a result of all this gatekeeping, the money is going down. It's not like you're paying them people $30 an hour out the gate anymore.
That's right.
So what is the problem?
I agree with you wholeheartedly. Yeah. So I was like, the AMA boy, they in everything, ain't they? I was like, they in everything. So yeah, the rest of the article kind of talks about um oh, they even threw a little thing into there. The AMA and Relias have co-developed education, delivering a total of 60 courses associated with 13 packages focused on various CPT specialty and topic education. Yeah, so it's everybody is in the mix. But yeah, so really, is it an actual coder shortage? I think there should be some more research done on this, and like we've mentioned and talked about this before, I think there's an opportunity for folks to really get a better understanding and picture. And I know this is specific to medical coders, but even just health information professionals as a whole, there needs to be a better um, understanding and advocacy for the skills that we possess, present, and have that can be beneficial to all of these organizations, and don't don't necessarily gatekeep and or pigeonhole us into certain roles. That'd be my 2 cents on that. Oh yeah, so I'm like, well, my friends over at the AMA does it again. Yeah, girl, wait a minute. When he said the heart arteries, I almost choked over here. Because that was funny. All right, all right. I don't know if we have any comments or questions over here in the on.
Which I'm trying to get. Okay, I'm trying to get Carlene to come to the stage.
Okay, so I don't know. I'm on Android. Not sure if that matters. She says she agrees with you. She is an NBC instructor. They pick and
Okay,
choose
she
who
said
they
that she was
want.
now.
Okay. There is no shortage. I know at least 10 students who passed the CPC certification looking for a coding job in Louisiana and Texas. I don't understand. Right. As soon as I saw that, I was like, but is there, like, again, I hear a lot of people, and what's the barrier? I don't understand. And I mean, we've talked about this before, but these are brand new people coming out. But then I guess we have to take into account um well, no, I'm not going to even say that, because if they've passed their certification exam, that evens the playing field. That's a mute point.
Thank you.
That's a mute point. So, because I was going into the what they, but no, if you got your certification, we don't even have to have that conversation about what you got, what type of instruction you got to get there. If you've passed, you got the paper, you ready to go. So, what's the issue?
Can I tell? I have 4 occupational licenses. 2 of them allowed me to have a temporary license while I was waiting to take my exam. If you have your paper in an industry that requires certification or licensure, that's the point of entry.
Exactly.
Everybody,
Exactly.
once you if your paperwork is right, come on.
Exactly.
So I don't know why if that's the issue. But um Carlene's up on the stage, so
Oh,
welcome,
hi,
Carlene.
Carleen. Welcome.
Hello, hello. I'm sorry, y'all. I'm feeling under the weather, so kind of a little scratchy. But I absolutely agree with you guys. And I don't know what it is. Just what Jesse just said. If you have this certification, what is it that stops you? And some of my students already have medical background, so even with the CPCA and the AB behind them, there is still like you have the experience. So
Mm-hmm.
what's going on? And again, like I said, between Texas and Louisiana, I'm talking both states. We having that issue, and there is no shortage. Like I said, I'm working 2 jobs. Probably could work 3 if I want to. I have friends who are working 3. So where is the shortage at? Especially in the HTC coded world, there is no shortage. People are there looking for people, so why not hire the aides and get the A off and train them the way you want? Because again, in coding, you training us how you want everywhere humana sitting, and everybody has their different ways of coding. So take them in, teach them, show them what you want, and let them go about their business. Now there will be no shortage. I just wanted to add that.
I appreciate that. You are absolutely right. And the only other thing I can possibly think, but they're touting growth. So that may not even be a factor. Like, I mean, there's only so many hospital systems. There's only so many medical practices. But as a certified marketable medical coder, the doors are open. You're not limited to just those entities. There are other areas that you can take that certification and perform those same duties. So I don't know if it's just everybody is, I just want to be in a hospital, or I just want to, I want to work for a hospital system, or I want to work for a physician system, or surgery center. I don't know if that's the mindset that's around it. That's kind of, but to your point, Carlene, the payers are always looking for coders. Folks are looking for coders, so they say. But what happens when the rubber meets the road and folks are sending information? Somebody recently in one of our sessions, somebody was telling us that their organization, it started with an S. Is it somebody? I can't think of the name. I'm sorry. But they were telling us that their organization was hired. They was hiring for remote, and they were taking people out of newly certified CPCAs that didn't have the 2-year. And I saw something else about that organization recently where they were saying that they weren't getting the numbers, or people weren't applying for them. And so I'm like, is it an issue with the organization? Like, it's not, you looking for people, but people running because some ain't right. I don't know, but somebody, this needs to be further, I think, research to get a better handle and understanding on what's the gap here. What's the gap? My mind is.
I want to add too, and this may be some of my fault too, because the first question that you asked, I know that payers are hiring, and I think I need to get more information on things outside of payers. I've always worked for payers in hospitals. So as an instructor, I think I need to get inform myself more on those things outside of it, so that I can inform my students and myself as well on where to go. And I think that's my fault, because again, once you get into it, it's like you kind of stop. And I think I kind of stopped there. And so going forward, starting today, I think I need to get more information so that I can tell my students, let's go outside of this. Let's look further out than just payers and hospitals.
Yeah.
But you also have to be careful too, because as somebody who has worked for contract companies.
Well, I wasn't necessarily thinking of them, but yeah, that's another.
But they're like the worst place to start. Because a lot of those people, they're not very good trainers, and you will learn some very bad habits very quickly. Because as a new coder, as with anything that you're doing for the first time, you need supervision.
You need a great foundation.
Right.
And I don't think it has been my experience that most consulting firms require some time under your belt. I don't know, and I may be wrong, and I may be out of touch. I don't think a lot of them take brand new, newly certified folks, because they want folks who have been experienced in XYZ specialty or XYZ location. So if they're looking specifically for inpatient coders, but again, if they are just out here willy-nilly, because and I get stuff in my inbox all the time. We looking for XYZ coders. Do you know somebody who can assist? Or are they just out here grabbing, reaching, and taking whatever? But to your point, Mr. Jesse, I think you're absolutely right. Folks need a firm foundation with some good training once they are certified and get into a position. initially. You're absolutely correct. Otherwise, they will be out here scrambling. And unfortunately, we may see now some results of that when you go back and be like, well, where you learn this? When somebody is doing audits and reviews on these coders and doing QA reviews on these coders, like, where did you get this information? And folks are not necessarily, some of these consulting organizations are in the business of getting the next contract. They're trying to get the next need, or getting the next contract to fill the particular need, and not necessarily investing the same amount of time and energy. And not all of them, but maybe some may not be best investing the same type of energy into their staff, the folks that they're consulting with. They should be providing, some training, providing education, providing information, updating them, keeping them abreast, so they are the best that they can be while they help the clients that they're serving.
But we're already seeing the fallout.
Oh, definitely.
In two areas. It's called overseas coding and AI.
Okay, let's talk about it. Oh, let's talk about it. True. And maybe that's another thing, folks. I mean, everybody's looking at their bottom line. They're trying to get the most for the less, for the least. Is this what this is gonna be? Everybody gonna be scratching and vying for a few positions that they have out there that coders could do, versus, we can pay someone overseas $9 an hour and they'll work all night long. And then they're working in different, time zones, and stuff is just 24-hour cranking or whatever. Versus I need to pay somebody here $25, $30 an hour for 8 hours and all the other components that come with the hiring package. I mean, I don't know. And then AI, that's a whole other level. You don't need nobody. You ain't paying nothing but for the machine. So,
but my whole thing is, just as the Yana, succinctly says, call a thing a thing. If you are trying to save money, then stop trying to hide behind this shortage. Stop trying to just say that there's no shortage because we're not hiring people.
We're not hiring
because we've outsourced, and what we can't outsource, we're going to rely on automation to do. Just say that.
I agree. And then that gives folks who are coming into the profession, who are considering, that gives them a choice. That gives them a choice to decide where I want to land in this. You're absolutely correct.
Because I just think that it is deplorable that certified people have to. I mean, I see it on LinkedIn all the time. You have people who have RHITs, RHIAs, and are trying to find jobs. Like, that should not be.
I don't understand. It's because it's it's a mixed message. On one hand, we looking, we need, we this, we that. On the other hand, well, we out here. What y'all doing for? What? And I like your call a thing a thing. Yeah, y'all know what y'all doing. Or y'all slow walking, quiet. What is it? Quiet quitting, quiet firing, quiet all of the things. Quietly trying to get the the AI and the overseas coders. I mean, call a thing a thing. Let it be what it is.
And if they also, what could also help expand the reach for coders is if this is a whole nother level of gatekeeping, if they started letting coders get into CDI.
Yep.
That would be a game changer.
That would be a game changer. And I always, I'm an advocate for the auditing piece too. Take them skills. Y'all can take them skills and flip it a little bit, tweak them a little bit. And there's opportunities on that end as well. It's going to be interesting. Again, maybe the AMA got some they got some additional skin in the game, and we'll definitely be on the watch and look out for more commentary related to the quote unquote coding shortage.
They had a lot to say lately.
A
I'm
lot,
expecting
a
we're gonna,
lot.
by the summer they're gonna have a whole climate change problem.
They got something in on everything, don't they? I'm like, wow, I'm odd. All right, the last, oh, we way up on time. The last thing I want to talk about. This is related. I saw a LinkedIn post recently that I was like, what? And this is about physician confusion. And it seems like it's some physicians out here that is that we would, when I was in college years ago, we would always talk about we are in the land of the lost. So the professor would be talking about stuff and we be sitting there scratching our head like, what? Like, we are out here in the land of the lost on this boat. We have no idea what in the world they are talking about. And so it seems that we may have some physicians who are out there as well. And I'm curious, like, why? Why are y'all out here in the land of the lost? Supposedly information went out, but let's take a look. So this comes from Dr. Ronald Hurst, who I listen to on a fairly regular basis on Monitor Mondays. And they also have different articles. He does articles, and he is I love Dr. Hurst. He always has a perspective. And so he said last week he read in a progress note from a hospitalist, quote, more than 50% of time spent on counseling and coordination of care, end quote. Yes, a note from May 2023, over 4 months after the hospital visit, E&M coding rules changed. No, not a doctor working in a small hospital without the resources to keep the physicians up to date on regulatory changes. And yes, the H&P did have, quote, 10 systems, a 10 system review of systems negative, except as an HBI, and a notation the patient was normocephalic. On January 1st, the rules changed to allow a highway to note completion, yet so many doctors are still taking the side streets. Why? And there's a lot. I even weighed in. There's a lot of folks that have been weighing in on this conversation. And my thing is, and I said this before, I do not understand when the E&M rules changed for outpatient, for office and other outpatient services a few years back. There was a whole education push. There was the AMA was all up in the mix, trying to make sure that the providers were well informed, well versed. I even had a few contracts where I provided education to physicians that work in the outpatient or professional space, making sure that they understand what these changes look like. It was a whole thing. When the stuff came down on inpatient, it was a whisper. I could barely hear, and I didn't understand. Like, why are they not telling them? Did they assume that because they did all the education for the outpatient side, that it was going to trickle and morph itself into the inpatient side? Because some folks are strictly hospitalists. They only work in inpatient. They don't do anything on the outpatient. So that stuff didn't mean anything to them. They didn't pay attention. And why? That's extra added stress that I don't need because I don't work in that setting. But you would think that they would have that same energy and put forth that same information to these inpatients, especially given the dollar amount associated with these cases. And when I read this, I was floored. Like, they for real holding on to the old way of, no, this doctor has no idea of what's happening. Some of the comments suggested, they're still using templates. They didn't get the education. They chose to and decided, this is the best route. I don't know, but it's a lot going on. And all I could think of first and foremost is y'all just gave the auditors that be carte blanche. Here we come. Carte blanche. Because if you are not, the whole premise of, and Dr. Hirsch, I think he mentioned it in a comment. He was having a wonderful back and forth with one of the commenters about the understanding that the medical decision making is what is critical and crucial to this documentation, which also supports medical necessity. If you're not documenting to that vein and you're still stuck on, oh, let me make sure I got enough bullets for the history and all of these exam pieces, you done missed the whole point, the whole boat. And you are low-lying fruit for the auditors. Period, point blank. You're right, Dr. Lisa. Good morning. Good morning.
Good morning, Dr. Lisa.
Good morning. And she also mentions a big mistake not to educate on an ongoing basis. You are absolutely correct.
That's it right there.
Hey, Vicky. Yes, we are spilling. We're trying to spill it today. That is absolutely correct. Go ahead, Mr. Jesse. I'm sorry.
I mean, it's all about education. I mean, Dr. Lisa laid it out. I mean, you have to educate. And I've just seen that there is, especially on the now, but what I found now, especially because of remote work, you don't have that face to face with, especially with inpatient providers anymore, because you're not in the hospital.
Okay.
You're not on the unit. You're not running into them and having side conversation. So it's a lot harder even when you're doing outpatients. It's a much more intimate setting.
Mhm.
You know, it's a whole lot easier to get a hold of the doctor and have informal conversation. Like some of them will even share their cell phone number.
Mhm.
You know, if you so you could there's less of an opportunity unless the hospital provides an ongoing education for physicians. It's kind of hard for them to stay aware of changes and even know that they need to change, because I know I just think that physicians need to be educated, just like Dr. Lisa said, constantly. Just like we have to be constantly educated.
Mhm.
We're always going to webinars, and we're
Mhm.
always doing CEUs that, like there's going to be a whole lot of CEUs about all these E&M changes.
Mhm.
So you have to stay abreast. And if nobody's teaching them, how can you can't hold people accountable for things you don't teach them?
And maybe that's something that the AMA, as you mentioned before, they need to keep clean their own house. Maybe that's something that they could provide for CEUs for physicians. Make sure that they are abreast of those types of changes as it relates to their documentation, and kind of mandate that at some point as one of the domains that they need to make sure that they have to maintain their license. I don't know if that's something that they do currently, but you would think that would be something that needs to be on the forefront of that, seeing as and also to your point about the documentation that we are seeing that is just off the charts. That should be a critical piece in provider education. You need to you need to know how to document. It's one thing to be able to treat the patient and medically and provide. We believe that you know what you're doing as it relates to practicing medicine, but we need to see the evidence of that in documentation. And getting that what you're thinking in ink or electronic now has always, it's been a challenge for years, and I don't understand what is it that is keeping them from basically mandating that these physicians or these providers out here get an understanding. Now, one sort of provider group, I think they got a better understanding. If you look at some of these MP documentation, they got a better understanding. And so maybe there is some room to collaborate and share and get some information if we wasn't fighting as much as we are.
But the MPs are like that because of training.
The training. That's what I'm saying. Physicians never got that. Years ago, back at the same academic medical center that I worked at, we actually inserted, because we were compliance, we inserted ourselves in this our physician medical training, and said we feel like they need to know, even if they don't stay here, if they go on, and this was again, I'm dating myself, years ago, because most folks were just opening up their own practices before they were being hired by hospital systems. But they needed to know the business behind what it is that they're doing. This is what the business looks like. And so we had a whole hour, if you will, just to kind of give a cursory overview, high level overview of what the business looks like, and why the importance of their documentation matters, and what that trickle down effect impacts as if their documentation is not correct. And so we did it as much as we could, and they appreciated it, they loved it. But again, we were just one little entity trying to affect some change in the students that came across our way. There are thousands and thousands of students that graduate every year. How many of them are actually getting a solid training on appropriateness of documentation in any setting? And that's part. We even talked about that even with the coders coming in. They need a good foundation. These providers, these physicians need a good foundation on documentation. And I don't know if they're actually getting it. And that's something that maybe the AMA should focus on.
Can I jump in on that?
Yes, ma'am.
And I just think that that's kind of twofold, because number one, provider educators get paid really well in a lot of these entities.
That's right.
And they are actually working for free, to tell you the truth, because a lot of the providers choose not to speak to them a lot of the time. And the more they put it on either their NP or they put it on their nurse manager, instead of taking the time to even speak with and see the provider educators, because they take their time to make slides and make PowerPoints to educate them on how they're using revenue and why the documentation is so important. So I think that a lot of this is the providers not even wanting to hear, because they know their job. And again, to the bullet points and to the EHR, the EMRs, and clicking, talking into the dragon has a lot to do with that. So I think, yeah, they're complaining about it, but y'all missing the point of the provider educators and taking time out to even do that. And so I just want to put that skill in there.
I agree. And this also takes me back to the importance of having a compliance program that has monitoring of this documentation. There should be in most organizations some sort of mechanism that is put in place that allows auditors to take a look at these providers and their documentation. And it's done not as a punitive exercise, but it's done to help them. So somebody is looking at what their documentation looks like, comparing that information, getting that data, and then providing a conversation with that provider on their specific. So it's not even generalized to what we're seeing, across this particular specialty. Is focused and targeted on that particular provider. This is your documentation, and let me show you the gaps. Or you're doing a great job. We may need you to help champion and train other providers or other physicians on the appropriateness of your documentation, because your documentation is spot on. I applaud those places that actually have the wherewithal to put those types of programs together, because because it's one thing to put it together, it's one thing to do all that work, but if you don't have any type of teeth in or skin in the game for that provider, it's all for naught. You have to have some sort of repercussion for that provider if, to your point, Ms. Carlene, they don't attend the training session or the education session, if they're not keeping up with the standards of what their documentation, there needs to be a bar. Hey, you got to reach this. Otherwise, we're going to hit you in your pocket. You may not get that bonus this quarter. If you can't, this needs to be part of, you got to have so many RVUs. You got to have, the percentage of your coding or evaluation or reviews needs to be XYZ. All of that should be part of a good comprehensive compliance program for these providers, both on an outpatient or professional basis as well as inpatient. I feel like I'm on the soapbox. And if you need some help, call your girl.
I just want to throw in, what's in my head, I'm thinking, okay, because I'm studying for the CDEO right now. Mm-hmm. And in-house compliance people. It might be somebody who has CDO or just a CPC person who knows their business.
That's right.
Just have somebody do that monthly, quarterly, however you want to do it. So go ahead and preach to the choir.
That's right. And these compliance programs, I mean, there's a role. Part of I'm a certified healthcare compliance professional, and part of the 7 elements, almost 8 elements of compliance is the regular auditing and monitoring. Yes, there needs to be a subset. And if you don't have the wherewithal in your compliance department, you got HIM, you got the department that can help you. Let them help you put this together. Ideally, it should be separate. Ideally, you should have somebody with autonomy to be able to go in, look at, provide those reviews, and provide that education. But if you don't, if you're in a very small facility or you don't have the necessary resources, somebody, and you got it in HIM, can take a look at those documents and be able to provide some sort of review. Baby step it, walk it slowly until you can get what you need. But ultimately, it benefits all. It benefits the organization. It benefits the provider. It benefits all. To me, it's a win-win. Go ahead, Mr. Jesse.
What is missing, period? And we because this whole conversation is really dancing around one simple theme: accountability.
Accountability.
And truth be told, most of these compliance programs are toothless tigers. It's just name only. Because first, the one thing that you can tell, that you can look at, if you look at any provider documentation and it's not up to par, that is a definite reflection of a poor compliance department.
You're absolutely right. So when they're doing those evaluations on an effective compliance program, if they don't have that piece involved in that, that's a problem. That's a problem.
Because I'm telling you what I see every day. I see people who are in the hospital 7 days, and all 7 notes are the exact same. The only thing that's different is the vital signs, maybe, and the plan. I have to read the plan to see what is different. Nothing is ever ruled in or ruled out.
And that's a problem.
Then what happens? Then it causes a back end on between CDI and coding, because you have to rely on the clinical information. Because you code per clinical information and also diagnosis. You need the clinical information to support the diagnosis. So then it gets into, like a back and forth. Like, I had an example, the person was severely, was in respiratory distress when they came to the ED. They were in the hospital like 17 days. They were placed on ventilation in the ED, was admitted, failed to be weaned. The intensivist diagnosed acute respiratory distress syndrome, which is more advanced than acute respiratory failure. I coded acute respiratory distress syndrome because you can code both as an exclusion. The coder writes to me and says that she has a problem with coding acute respiratory distress syndrome because it was only documented by the intensivist and not by any other specialty. I'm like, but you look at the clinical evidence. I said, the person failed to be weaned off the vent. They were on the vent for a week. That's not normal respiratory failure.
Right.
But those are the kinds of things that poor documentation cause on the back end. Because then you go back and forth and that delays billing.
And I think there's also an opportunity even for the CDI programs. The CDI programs and compliance. You guys are seeing these cases. You can identify the problem children, if you will. Again, there should be a broad regular monitoring of all of the providers, but you already know who your problem children are. And so you can provide further information and further detail related to the documentation of these problem children, if you will, problem providers as it relates to documentation, and allow this additional information. I know they're tired of you hear query fatigue, and they're tired of this, that, and the third. However, clearly you're not getting the message. You're not getting the information. Again, to your point, accountability kind of puts the stamp on all of this. It stops most of this foolishness. Accountability and hitting folks in their pocket. Oh, folks, pay attention. Oh, well, wait a minute. And then folks pay attention to things that they know that are important. So if you're shining a spotlight on, hey, we need to make sure that our documentation meets XYZ, and this is something that we're going to look at and monitor on a regular basis, people like, oh, wait a minute, hold up, let me make sure my stuff is, because they're very competitive people too. And so they will try to outdo the other. Well, wait a minute, they got this. Well, I need to get this and that and the third. It's yeah.
Can I, as you were talking, I had figured out how we can solve this in a month.
Come on, monthly. Come on, 30 days.
If you tie providers' bonuses to their denial rate, it'd be a game changer.
Woo! All right.
Because I'm telling you, I know for a lot of how you can have somebody in the hospital for 17 days and have an unspecified code as a principal diagnosis, I'll never understand.
I don't understand that one at all. And then you be in your feelings. Well, but the other part of it is, do they actually know and understand what happens downstream? Are they understanding the impact of what happens to the hospital stay that doesn't get paid or has been denied? Or do they just go on about their merry way to the next one? On to the next one.
They go on about their merry way.
That's what I'm saying. On to the next one.
Because they have other departments that clean it up.
They clean it up. So that's going to be the challenge, is getting those enablers out the way, or getting those enablers to back and sign on to a program of accountability. That's going to be the challenge. Because they coddle. They, we want to make sure we, you know how it is. You know how it is. This has been good. Look, I'm almost out of tea. This has been good. I know we done went over. I'm so sorry, y'all. But we couldn't stop. It's so much. The juice and tea has just been here. I think I need to add some lemon juice to my tea, because it's been here. Oh my God. But I do love this time provider denial rates to their bonuses. That's a strategy that I wonder if folks have thought about. But, and they may have thought about it, but again, you gotta get over the hurdle of those who, want to turn a blind eye and think, oh, well, they're really not responsible. They should know. The hell? They are the reason why. It starts at the documentation. It starts at documentation. And why not help better the documentation of the provider? Everybody wins. The patient wins if they have better documentation. The organization wins, and the provider wins. Everybody wins. It's a win.
Because they don't want to. They feel like somebody's trying to tell them how to do their job. And what I've told every provider I've ever had to have a conversation with is, I'm not trying to tell you how to do your job. I'm trying to tell you how you can get paid for doing your job. I'm
trying to tell you how to keep the money you got paid to do your job. Because it's one thing to get the money. It's something totally different to be able to keep it. Because if you keep on with these bad habits, bad things can happen to you.
Just describe what you do. That's more accurately.
Just describe what you do.
That's where nurse practitioners come in, because they teach you in nursing school from day one. When you write your first little practice, nurses note, if it's not documented, it wasn't done. Period. That's your mantra through your entire nursing career. So that's why nurses document meticulously. If you didn't document that you called the doctor, you didn't call the doctor. If you didn't document that you checked Mrs. So-and-so's labs, you didn't check the labs. So that's why the documentation is so much better on the nurse practitioner's front, because they drill it on you, and they always they prepare you for court for day one. Right? Like it's going to be like you're going to be on trial.
And one of the things that we were always taught, like, check them nursing notes. If you can, go to the nursing notes. You'll find some wonderful gems. Just look through the nurse's notes, especially on them inpatient stays. inpatient information.
I've seen cases where nurses' notes have saved a hospital from a hack. And like a PSI, you don't want too many of them either. But it's interesting how it all plays out.
It is. Well, this was good. I'm excited. Wow. I feel like we offered some solutions. We had a strategy. This was great. You know, I'm all about being the resource. So this did what I needed it to do for today.
Like I tell you all the time, Clarice, this is why I appreciate and I'm glad you created this space because we're the only people, and I'm going to say that.
Say it. Put it out there.
We're the only people on the internet that are having these kinds of conversations.
Yes.
At the coding level. Because
yes.
Everybody else wants to make it, they want to talk about, how to study for your CPC. It's all cute and flowery. No.
It's way more, it's deeper than that. It's deeper than that. Because even once you get to the point where you have your CPC, then what? Or you have your coding service, your CCS or CCSP, then what? Then what? There's more to it. And you got to be in the know and be receptive to understanding. One, you done signed up for something that's going to be lifelong learning with multiple changes. And then, as we've always talked about, knowing the why behind the machine. You got to know the why behind the machine. You got to know. That helps you determine how you need to move. Always. This ain't checkers. This is chess. Oh, this was great. This was great. All right. All right. So, well, we are way over time, but I think this was good. I think it was good information. Thank you all again for joining the Saturday morning tea. Was the tea spilled today? Yes, I believe so. All kinds of tea, hot tea, lemon tea, you name it. If this information was valuable for you, help us share this message and our platform with others by sharing the video and subscribing to the channel. And don't forget, as you are signing out and leaving us today, don't forget to hit the thumbs up or like button. You can also check out the Coding Nurse channel on YouTube, as well as our channel, the Professional Reimbursement Network. Over there at the Coding Network or the Coding Nurse, they got all kinds of gems over there as well. So definitely hit the like button. That engagement, having others see it, this allows that engagement that you have with us, providing comments or liking, this allows us to get to and reach other people that may need this information that we just don't know yet. And we want to get to know them. So help us push this message to the masses. Maybe somebody who is watching can be one of those change agents to help get a better understanding on some of the things that we talked about today and some of the strategies that Mr. Jesse dropped. So yes, help us, help them. And I got a personal goal. I'm trying to get 10,000 subscribers. So please subscribe to the channel and share with your friends. Say, I know this lady over here. She's talking. You may not even be interested in what she's talking about, but just subscribe to her channel. She'll give you a laugh at least once a day, once in a while. Also, last but not least, to my Clubhouse folks, even though things are changing over here in Clubhouse, just join our house. Come on into our house and you'll get notifications of when we come on live, which is on Saturday mornings at 9 a.m. Eastern Standard Time. Again, this has been great today. Great today. We're probably going to have a little meeting after the meeting. Yeah. We will be putting together some opportunities to get folks who want to be part of the meeting after meeting soon. So be on the lookout for that as well. Again, thank you all for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, have a safe holiday, and we'll talk to you soon. Bye-bye.
Bye-bye, everybody.